if you can prevent diseases, that's what we call nirvana.
Yeah.
That's what you want.
Yeah.
People not waiting for them to get sick. Every rand you spend on healthcare is not actually an expenditure, it's an investment.
Yeah.
So healthy populations actually become more productive.
Yeah.
So for me, I just think there's a shift that is needed in leadership.
Please join us as we delve into the work of SAMA, issues around universal health care, the National Health Insurance Act, artificial intelligence, and the pivotal role of leadership in achieving good health outcomes. So, Dr. Theo, thank you for being here.
Thank you so much, Mandisa, for inviting us.
We're very excited to have you here. Let's kick off with you telling us a little bit more about the man behind the physician.
No, thank you so much, Mandisa. I also really appreciate the opportunity. So my name is Mzulungile. So then you'll call me Mzu because it's short for Mzulungile. And Theo is short for Theophilus. And the surname is Nodikida. I'm originally from a small village called Pedi in the Eastern Cape. That's where I matriculated in 1999. I don't know, where were you in 1999, man?
That trick is not going to work with me, Dr. Theo. You're trying to age me.
Okay. So, but then I was very lucky. I think I must say that I was lucky at those were the early years of the South African democracy. So I got a scholarship, a medical scholarship, to go and study medicine in Cuba. I spent the first 6 months in that island learning Spanish because we needed to be trained in Spanish so that we could receive our medical training in Spanish. I also just think that if you were to take me back to 2002 and give me the choice to choose a medical school, I would still go back to Cuba. Wow. Just because of the unique experience that the country presented to us.
That's saying a lot.
Yeah. So then I completed there in 2008, and then I came back to South Africa at the University of Pretoria, which is where I completed my MPCHB. Then I went home in the Eastern Cape to work in PE for about 2 years as an intern doctor. And then I went home in my hometown of Pedi. I worked as a medical officer, community service for 1 year. And I was then employed permanently as a medical officer responsible for the maternal unit of that hospital. But I must just share with you, Mandisa, that for me in medicine, my passion was in obstetrics and gynae. So I did a diploma in obstetrics and gynae with the colleges of medicine around 2013. But two things came to my mind at that time. One was that if I were to practice obstetrics, I needed to practice it watching my back because of the litigation. It's one of the most litigated specialties in medicine. And secondly, I also felt that I could play a bigger role in the business side of healthcare and the leadership side of healthcare, developing policies and all of that. So then I needed to figure out what would prepare me for that kind of role. And then I joined the Rhodes University Business School, and I did my MBA with them. And luckily, I think during the time when I was busy doing my research, I then got appointed as a senior medical manager for the Nelson Mandela Academic Hospital in Umtata. That's another experience that I wouldn't trade for anything. It prepared me for roles like the one that I'm currently playing now as the CEO of SAMA. I think the experience I gained there leading senior specialists really played a role in preparing me for what I'm doing today. And I think my last beat is that I then was lucky again to get another government scholarship, but this one was from the Chinese government to study public health with one of their universities there in Beijing called Peking University, which I completed in 2023. And that time I was now a director for clinical governance at the same hospital, at the Nelson Mandela Academic Hospital. I was there up until last year, end of Jan, and I started as the CEO of SAMA on the 1st of April. But I've been a SAMA member since I graduated.
Yeah.
No, Mandisa, I think Cuba, for me, I think it was more than just medical training. You're right. I mean, I think the country built some resilience in me. And I've seen some of my colleagues as well. I mean, guys who were trained within our era, they literally are leading some of the institutions in South Africa.
Yeah.
The way they also train you there is not the traditional way of training medicine. They give you the system itself. So they break it down for you from the highest level of the system to the basic unit. I mean, we spend most of our time with the communities, with the Cubans, doing the basic things with the doctors who were leading us there before we could even go to our clinical years. So that's why I was saying in the beginning that, I mean, even if I were to be taken back to that time and they say, here's still you have a scholarship, but you could go to UCT or whichever university local, I'll still go back.
Yeah.
Yeah, I will still go back. I think we've gained more than just medical training there.
Yeah.
Yeah.
So if South Africa were to adopt a similar education system, training system, would that be a good thing for South Africa?
South Africa can adopt some of the aspects of the Cuban training, but not all, because I think the disease profile, for example, is different. The setup in terms of the legislative framework is also different. But I think the community-oriented approach in healthcare is for me the best.
Yeah.
The focus on primary health care, on prevention of diseases before they actually happen. I mean, if you look at our country, we almost are curative orientated. So we wait for people to be sick, and then we intervene to try and heal. But in Cuba, it's primary health care focused. It's about what you eat within the budget that you can afford as a society. I mean, one of the amazing things, Mandisa, that I can share with you, and it's still a dream of mine to actually implement in South Africa, just because you've asked, it's how the Cuban community addresses the issue of poverty at pregnancy. So we know now, I mean, medical people would attest to this, that the most important days of your life as a human being is the first 1,000 days of life. So that's from conception to your second birthday.
Okay.
Now, that period is critical in such a way that the food that you receive inside your mother's womb and everything that happens with your mother during that time and after you're born can determine what type of a person you're going to be in the future, what type of work your level of intelligence and all of those things. So what the Cuban government does, they literally aim at picking up pregnancy early.
Yeah.
They then do an assessment of each and every household that's got a woman who's pregnant. They assess the socioeconomic status there. They instead of giving a grant like we do in South Africa, they literally in the community create a feeding center. They call them the maternal homes.
Yeah.
So the ladies who are struggling socioeconomically, then they are fed at that center, and then they go back home.
Yeah.
So you literally are pulled out of your family to access good food, and your people are actually trained to treat you better during that period, because those are the golden days of the person that you carry. And as a result of this, Cuba rarely has a baby who's born underweight. They rarely have genetical malformations because they can be picked up by ultrasound during early pregnancy, and a decision can be made early. So this is one of the things that I still wish I could do for my own country now, especially in the rural settings.
Yeah.
That we could maybe work collaboratively with the social development department to create these homes, so that it's more expensive to try and bring a baby who was born underweight to the normal weight than making sure that the baby is actually born normally under normal circumstances and is healthy.
True.
Yeah.
I'm just trying to wrap my head around what you just said, that one of the things they do well in that area is do their best to pick up pregnancy early.
Yeah.
That means, what do they do? I'm just trying to imagine my own pregnancy experience.
So-
and I'm
so-
like, what would they do to pick it up early?
So one of the things that Cuba does is public education.
Yeah.
And that goes, they used to call it empowering the community
Yeah.
to take care of their own health.
Yeah.
So when we were students there, we would be sitting at the polyclinic, in a clinic in a village, and ordinary people would come in and say, hey, just check my blood pressure. You know, and young ladies would come and say, but I am sexually active and I've missed my period, so I would like to be tested. And so the level of education on health-related things for that population is very high.
Yeah.
So meaning, the minute they miss their periods, then they would report.
Yeah.
Especially if they know that they are sexually active.
Yeah.
So you've got a level of culture that is a little bit higher in terms of the population itself. But that's because that has been driven by the leaders within the society themselves. So they talk about these things. You know, I mean, in Cuba, one of the things that we struggled with when we compared the systems was the HIV patients. We literally did not have a fully blown AIDS patient in Cuba. We did not see them because people actually test, and the government has actually made it almost mandatory for people to test. So it's almost like, I know that globally sometimes they were being blamed for human rights, but they almost made HIV a notifiable disease at that time.
Yeah.
And it helped them to manage the situation. So I think it's a question of empowering the community about key things that could have far-reaching implications on their life and their family life.
Yeah.
You know,
Yeah.
later on.
One more thing about your Cuban experience before we move
Okay.
back to South Africa. This is a South African show after all.
Okay.
You mentioned that your training, you spent some time there and then you completed your degree here.
Yeah.
What does that mean? Was it
So-
was the program broken down in that way, or okay?
Yeah. So in the agreement between the two governments is that you do your 5 years of training
Okay.
in Cuba.
Yeah.
But to be integrated back into the South African disease
Okay.
profiling system,
Yeah.
you need to do your last year
Okay.
here.
Makes sense.
So basically we write 2 exams. So we come back, we have to pass the South African final year,
yeah.
because there you are now examined with your South African colleagues. But once you're done with that, you then have to write a state exam from Cuba,
Yeah.
you know, which I think most guys pass.
Yeah.
I don't remember guys struggling post the South African year to write a Spanish exam.
Yeah.
Because the only problem is the transition from Spanish. Your medical thinking is in Spanish, your patients were Spanish speaking in your training.
Yeah.
And then the last year here in South Africa, it's one of the most difficult years because you now need to train yourself to medically think in English. And also the textbooks, I mean, the abbreviations, they are horrible.
Yeah.
You know, I have a horrible experience. I think in my first days at the University of Pretoria, one of the professors asked me what was wrong with the patient. Mandisa, I could tell that this patient had a heart failure. You know, and the congestive heart failure. So, but I couldn't say it in English.
Yeah.
I just couldn't get the term in English. So I ended up saying to the Prof, I know that the heart of this patient is failing, okay? I know.
Yeah.
And I can tell you the medical term in Spanish, but I can't tell you in English. In Spanish,
depleted.
I mean, in Spanish we call it congestive. It's insuficiencia cardíaca global. But when I say that to the Prof is like, what the hell are you talking about? You know? So we had to spend more time with our English books just to catch up on the terminology in English. But I mean, the knowledge was there.
Yeah. Fascinating.
Yeah.
Okay, so you are currently the CEO of the South African Medical Association.
Yes.
Who is SAMA? What do they do?
So thank you very much for that. I mean, I get paid for just saying. So the South African Medical Association is a national medical association. So we represent the needs and interests of doctors across the public and the private sector. Mm-hmm. We also represent them regardless of the specialty they choose to follow. Mm-hmm. So we are the National Medical Association. But our purpose of existence is basically to unite all of them for the health of the nation. So there's a bigger purpose. Mm-hmm. You know, and if I can interest you just with the history of SAMA. So before the dawn of democracy, SAMA was fragmented into different racial groups of medical associations. And I think it was in 1998 when they decided to come together, black and whites, Indians, and they came together and then they formed SAMA. So in the past, there was something called NAMDA, National Medical Association of South Africa. But when the amalgamation happened, they had one National Medical Association. And I'm very honored to be one of the leaders of SAMA today. But I've been with the association, as I indicated earlier, since I was a junior doctor. I think I was their first international liaison officer at the junior doctors level. You know, so then I joined the board of SAMA. I joined in 2018 as the head of finance for the board. Up until I got appointed as the CEO, I was still playing the role of the head of finance.
Yeah. What it's not obvious to me, for instance, what you mean when you say the interests of medical professionals. What does it mean?
So, for example, I mean, doctors have different challenges in different settings they find themselves in.
Yeah.
So now you literally our value proposition to doctors is that SAMA is here for you.
Yeah.
So we start with you as a student. So as a student, you need mentorship.
Yeah.
So SAMA has got a student membership and it's got retirees, people who've been teaching in medical schools. So we provide that mentorship for students. If you are a junior doctor, the contracts you sign on the day one when you start, it's like you need a lawyer. So we provide that guidance there. And also, I mean, now the big thing that in the public sector people are talking about is commuted overtime, which is money that is paid to doctors for working over and above their normal hours. There's also a policy on how do you pay a doctor when are doctors allowed to work both in public and private? And that's basically one of the reasons SAMA was formed, is because doctors can be private in the morning and public in the evening, or vice versa. So we need to be there and guide from an ethical point of view, all of those things. For specialists in the private sector...
Just before you move on, when you say from an ethical point of view, I wouldn't have seen that there's an ethics issue. Could you explain what that means?
So let's go to the RWAPS policy. So RWAPS stands for remunerative work outside of the public sector.
Okay.
So this is a policy that government introduced to make sure that, one, doctors are able to work in the two sectors.
Yeah.
So you could be employed permanently by the state, but you are then allowed to do your work privately. for you to be exposed to the disease profile of the other population that is accessing health in that side. Also, the equipment might not be the same. So you could bring in skill from the private sector and say, oh, by the way, we can bring this thing into the public sector. So that was the idea. Also, it's an economic opportunity for doctors to actually work on the two sectors. But the issue there was, how do you monitor that I actually work for the state and I'm working my hours in the state, but then I start working for private in my free time, but I'm expected to be back in the state in the morning. So you needed a system that almost governs that. And that's where the ethics comes in, because you would have some people who would, instead of being at the state hospital where they are full-time employed, they would want to do their private patients on the state, on the time that is supposed to be on the state. And then that's an ethical issue there. So we provide that kind of guidance so that people remain within what they are allowed to actually do, and the population benefits either way.
Yes.
Yeah. So that's the issue around the ethical thing. So with the private sector, it's almost similar with what we do in public, because we play like a role of a bridge between the doctors who are employed in the state and the engagement with the states. Similarly, with the private sector, we've got the funders, which would be your schemes, your medical schemes. They now have a Health Funders Association. But then you've got our members who are private GPs, you've got our members who are specialists. So the funder negotiation is a critical role that we play. As we also actually own the license for coding, which is almost like a diagnostic system that allows schemes to pay doctors. So we have that license as the medical association. We actually, one of our plans is to train more coders, because we identified a gap in the market that there's less coders, and we need more. Even in the state, I mean, there are people who get to be treated at some of our bigger hospitals, but because the state doesn't have coders to actually claim for the state, because, I mean, some major operations there for people who have medical aid, you can actually claim for.
Yeah.
Similarly with the RAF, I mean, you can use the same coding system to claim. So we've identified that gap. So that's the kind of a role that SAMA plays. But we also have a responsibility at the advocacy level for a meaningful contribution to policy development of the country. We also believe that professionals like ourselves need to shape the policy framework of the country, and also the direction that the country takes with the ever-changing environment that we operate in. So those are the major roles that I think SAMA is preoccupied with. I mean, at national level, we can talk about the NHI, we can talk about how do you ensure access for the population, because if you are uniting doctors for the health of the nation, the most important thing then becomes the health of the nation.
Yeah.
Because doctors don't exist without patients, and
Yeah. And I have seen that SAMA is one of the entities that are challenging in court, a government in court, relating to various things.
Yeah.
And I've also picked up that relative to other players in the industry, in the health industry, your challenge is different.
Yeah.
Could you take us through that? Why are you challenging government? So why are you making our government spend our taxes defending legal challenge against you guys?
So it's an unfortunate thing. It's really, Mandisa, it's unfortunate that we had to take government to court for this. Maybe just for context, SAMA is part of what is called the Coalition of National Medical Associations in Africa.
Yeah.
So that's a regional body. We're also a leading medical association within the World Medical Association. So that tells you that on major global issues, we really are a bigger player there. So universal health coverage is a concept which was developed by the WHO, which is the World Health Organization, is something that SAMA agrees with government on. So this is important.
Yeah.
We also believe, I personally believe that universal health coverage is probably the best thing that public health has to offer. I'm being honest with you. But I think where that's why I'm saying it's unfortunate, where we differ is how government has decided to go about this. I'll make an example, Manisa, about just basic building blocks of a health system. So you've got about 6 of these. You've got human resource, you've got finance, you've got information systems, medicine, the infrastructure and equipment. So when you look at what is government actually emphasizing here, it's finance. Granted, it's the most, probably one of the most important building blocks. If you take it with, in the past, human resources, but now information systems almost trumps them. With what technology has brought in. That becomes almost central. So what we are saying to government is that if money was the only problem of the public health system, we wouldn't be having departments of health in the various provinces sending money back to Treasury like they did in the last financial year. So if money was the issue, then we probably wouldn't have that. But one of the key building blocks in health systems is leadership and governance. And with the right leadership in place, especially at the local level, at the district level, all the way up, you then would have that money spent correctly, for the right reasons. So that's the one major thing that we're saying, government, please, can we consider these other critical building blocks that are important to take us to universal health coverage? The second major thing, which almost renders the act outdated, is the issue around registration and what we believe South Africans need is almost like a framework. We call it the universal electronic health record for all South Africans. Meaning, Manisa, you can access healthcare between the two systems wherever you are in the country, and we will have your history.
Yeah.
If South Africa can achieve that for us talks to the concept of universality.
Yeah.
So if we can achieve just a universal electronic record for all South Africans, the spin-offs from that kind of an investment would immediately deal with what government is dealing with in healthcare, which is medical legal. So from a medical legal point of view, the public health system loses documents because they're still using paper. It's paper-based. But if you have that information stored somewhere in a secured cloud, you are able to defend your cases. If you use AI tools to actually capture the notes and the word rounds of doctors. So all the work that is routine, that needs to be done, manually, you can use machine to do that and let the doctors focus on the key things.
But I'm a bit confused. That makes perfect sense.
Sure.
Why wouldn't this make sense to government? What has been government's response to you in all the engagements you've had around this particular issue? We'll talk about the rest as we go on.
For me, this is why I'm saying it's unfortunate. I think one of the things that have been a problem is the changes in leadership within government. Different people have come in and led the Department of Health. But SAMA has made submissions since the Green Paper, and we've been making the same argument to say, look, there are other things to consider here, colleagues. We went to Parliament So we didn't just wake up, Manis, and said, yeah, no, we're taking government to court. No, we made submissions. I mean, we went to Parliament, we presented. I even remember we had an engagement at the summer head offices with the then Minister Zweli Mkhize. And we thought we were making inroads, in fact, during his time.
Yeah.
I mean, he was one of the leaders who was listening to the profession and was receptive. You know, but I mean, changes within the health department come, and people, the personalities of the various ministers change, and we almost feel like government almost rushed this process to get it through to Parliament in 2003. And in fact, Manisa, SAMA we contribute to what is called the presidential universal health pillars. They have something that is hosted within the president. We are leading there with other formations of healthcare workers. But we noticed that when they were signing that off, they had now brought in the NHI into the whole compact. It's called the Presidential Health Compact. But I'm like, but you can't do this. You can't push these things. You're supposed to have a conversation, a proper conversation with your National Medical Association. And in fact, with all the healthcare workers, because we don't believe that as doctors we've got the monopoly of wisdom to do this thing. But engage professionals so that you've got their buy-in to implement the system. You know, and that is where I think government has literally not I don't want to say failed South Africans, but they failed us as professionals. You know, because our contributions, however constant it was throughout the years, it was never taken into account. Like one of the simple things we're arguing, there is also the power that is centralized within the ministry. So you can't build a national health act around a persona or a personality of the minister at a point in time. You don't know who's going to be your Minister of Health and what they can do with that level of power that you've given to them. So there's so many things that we could have just sat down. And we hope that, I mean, government would, I don't know, at some point maybe recognize that it's actually not the most effective way of dealing with the UHC, to deal with it and make judges make a decision on something that we have expertise on, and they would come and listen, you know, and we can agree to disagree, because where we want to go as a country is UHC, which is universal health coverage, but we just differ on the minor details of how we get there.
Yeah. I guess that also takes us back to the point you made earlier about leadership, inadequate leadership, and that more effective leadership is required, because I'm listening to you talking about change of guard, rendering the system catatonic. It's not obvious to me why it should, because it's not about the person, it's a policy issue, it's a government issue. So how do we move from here? How do we fix that? What needs to happen?
So I just think that our leaders need to be more, how do I put it, almost more receptive of the voices that do not necessarily agree, so that you can learn in any process, you know. And especially when you know that you are deferring to expertise, you know. So if the people who are supposed to be leading your health system, people who are intertwined with their own patients, and I say this for all healthcare workers, I mean, doctors, nurses, and all the other allied workers, we have an understanding of how this system can work, and how we can deliver universal health coverage to our patients. The least that government can do is to listen, and we can agree to disagree on certain things, but key issues which are global, leadership and governance is non-negotiable. The impact of technology in healthcare today needs to scream on the NHI Act. It's not there. It's not. You don't see it, and I mean, technology and AI didn't just affect healthcare.
Yeah.
It's everywhere. It's
Yeah.
in every sector.
Yeah.
So you can't pass a law that just ignores the fact that there's technology now that can be used. I mean, when I read the green paper and the white paper, there was my favorite line there was that primary health care will be the cornerstone of the NHI. That debate has died a natural death, as we say in our space. It's gone, it's not there anymore. The focus now is almost like a tunnel vision. Where do we get the money? Do we tax people more? So the debate is gone. In the system, I mean, an example of an NHI system that almost works is the NHS in the UK.
Yeah.
It's very clear there that the debate started with the profession. The GPs are the gatekeepers of the system. You have almost, in countries that they actually cite on their papers, in one of the cases that government responded, they cite, I think, Taiwan, and I can't remember this other country in Asia. In those countries, you've got what is called the purchaser-provider split.
Yeah.
One of our arguments is that government cannot be a rel-player player. So you can't be responsible to make the hospitals to be at a certain quality for you to purchase services from them, but you are the same person who's responsible for quality, you are also buying. So
Yeah.
you need a system that allows almost like a private hospitals, and even if it's a parastatal of hospitals that owns the hospitals and reaches a certain standard, then you know you're buying quality for our people.
Yeah.
You know? But you can't be the one person who's responsible for the quality there and also responsible for buying. I mean,
Yeah.
that
It's
just doesn't.
segregation of duty. It's entrenched in our governance systems everywhere, isn't it?
So these things you would think leadership should know.
Precisely.
You know, so I think for me that's we are at the critical moment in our country now, and I'm hoping that we don't have to go the longer route, because it's going to take longer to deal with all the cases. I'm just hoping that as we reach out to the presidency and the minister himself, I mean, Minister Mtsoleri did wonderful things for this country. I mean, the introduction of the ARVs in his early days as a minister, that was a game changer for our life expectancy and all of those things. So from someone who's bold to take decisions, we don't doubt that, you know. So we hope that boldness can come back and say, okay, let's park the court things. Summer, come here. What's the issue here? Can we deal with these issues? Dinosa or all of these other specialists who are in the private sector who have challenged. I mean, the Hospitals Association of South Africa has also laid a court challenge against the NHS. So listen to those people and find out if you can find a common ground for the benefit of the nation.
Yeah. Saying you've raised a lot of significant points that I'd like us to discuss a little further.
Okay.
But I'd also like us to just wrap up this NHI thing, because I don't want those issues. I see them as being issues beyond just
NHI.
NHI.
Okay.
But just to wrap up NHI, where is the case now, and I mean, what are you seeing happening?
Okay.
To that thing?
So we filed our papers. So we obviously going to have to wait for the ministry to respond. And they did ask the minister on he had a press briefing, I think, about a week or two ago. And he actually said, look, we are preparing responses for all the cases.
Yeah.
And some are being the last to file. So we're expecting them to respond. Just to say that in the NHI, the various cases that were launched, the difference between ours and the other cases that were launched is that almost all of the ones before the summer case are focusing on one around one section of the NHI Act, and that's Section 33, which takes away the medical aid schemes.
Yeah.
Says they will not be allowed to operate. And ours goes beyond that because we represent the voices of the profession, but we also represent our patient. Just an example, if NHI was to be implemented tomorrow in its current format, my people from where I come from, the rural, deep rural part of the Eastern Cape, I mean, at least we have a hospital, which I'm not sure if it meets the standards to actually render the services in an NHI area. That's number one. But what about people in rural Mkanduli who don't even have an infrastructure to begin with? So again, depending on where you are in the country, you will have limited access to what is called the NHI. They talk about registration, which is regional, meaning you must register where you are. You can access healthcare somewhere else where you are not registered. That's outdated. People move.
Yeah.
And it's the same country. So you should be able to access healthcare anyway.
Yeah.
So just those issues that maybe the business focused cases that were launched before us are not putting to the front. The impact it will have on doctors, the amount of hours that they would have to work, which will impact on the quality of care that they will be able to render. So we raise some of those issues that were not raised in the previous case.
Cool.
Yeah.
You've just triggered the memory of this whole process, this bureaucratic process around the NHI. Aside from registrations for patients, for citizens, it's also registrations and accreditations for doctors.
Yeah.
What is that about? Why does a practicing doctor need to tick more boxes to practice in NHI?
So this is what we're asking ourselves. I mean, for your practice as a doctor, there's a certain criteria that the Office of Health Standards is supposed to tick according to the bill.
Yeah.
So you must now, let's just make an example of two different settings altogether. So a practice in Alex, right, and a practice in the rural villages of the Eastern Cape. You have to, the standard is important, right? We must not run away from that. The standard of the practice is important. But, I mean, some of our members have raised an issue that I've chosen to practice in this rural setup where I don't have running water, for example.
Yeah.
So what will the Office of Health Standards say? Do I qualify? Do I not qualify? Again, even the facilities themselves, the hospitals that exist, they have to meet a certain criteria by the Office of Healthcare Standards. But again, who is responsible to make sure that a hospital in my village, for example, meets the criteria? Who funds that hospital to meet that particular criteria? I mean, there's a hospital in Stegspruit. I was in Bloemfontein with the CEO of Busamed. And the CEO was saying to me, they don't have an X-ray machine, a basic black and white X-ray machine. So then, if we can't put up a basic X-ray machine in some of these rural hospitals, then what are we talking about? Because those are the basic things that needs to be in place first for this hospital to be able to get the accreditation, So that's why the purchaser-provider split is an important discussion that we must have as a country. But I mean, in the NHI, I think we're still optimistic at SAMA that leadership will probably respond, especially we have also just led all the healthcare professionals into developing an alternative to the current document of the NHI. Because we also don't want to be seen as just people who are complaining and not bringing the actual alternative and how you can do this. So there's a document that we've prepared. We've sent it to the presidency. We've sent it to the Ministry of Health. I mean, people who have read our primary healthcare focused policy reform in 1997, where we're focusing on primary healthcare. At that time, we didn't have the advent of technology. But if you focus on primary health care and access with technology and AI, I mean, the kind of quality that we can give to our citizen is at another level.
Yeah.
You know, so in that paper, I mean, our document is almost, our proposal is almost a mirror of that 1997 white paper on health reforms. But it's augmented with models on financing and how do you incorporate technology to improve access.
Yeah.
You know, and how do you leverage the limited human resources you have using technology to cover broader areas. I mean, you could be one specialist in radiology, for example, sitting at home but interpreting images from various hospitals. You know, so the amount of work that you can do with the advent of technology for various hospitals that would in the past need their own individual radiologist on site is, I mean, technology has just closed the gap.
Yeah.
You know, but we're hoping that, yeah, people will listen, people will read, and people will somehow.
And tell me, is the document accessible to South Africans?
Yes.
Where can interested South Africans?
On our website, it's
On your
available.
website?
Yes,
And what do you call it?
It's called, the actual group is called UHAC.
Yeah.
So this is almost a coalition on universal health coverage for South Africa. But I can also make it available to FireSide. So
Yes,
that,
perfect.
I mean, it can be available and accessible.
Post the link.
Yes.
Wonderful.
Yes.
Okay.
Yeah.
Let's go back to the question around AI and technology in general.
Okay. That's my favorite.
I love the positive spin you are putting on it. It tends to be a bit scary in some circles.
Yeah.
You know, a lot of focus on AI taking jobs.
Yeah.
And one of the things you've just highlighted now is where it actually augments services and enables the profession to do more with less. And I think this is particularly significant in a context where we have a shortage of doctors.
Yes.
Or at least that's the narrative.
Yes.
And we must go back to that at some point, because I'm aware that as much as we're talking about the shortage of doctors, we're suddenly experiencing a high unemployment rate of qualified doctors, but starting with AI.
So maybe let's take a step back a little bit. So in the main, AI, which is artificial intelligence, we accept that this is almost machines doing things that humans would normally do.
Yeah.
So they almost, with learning, they almost assist humans to do things more efficiently. Mm-hmm. And this is in all the sectors. So, I mean, you go into policing, whole agriculture is there. With healthcare is seen as almost the most slow of the sectors to adopt healthcare. And one of the reasons is that doctors and other healthcare workers felt that this is almost something that is coming to replace them. And I mean, then one of the responsibilities we have is to actually inform and empower doctors that this is something that helps you to make decisions efficiently, and it actually can do your other routine work and helps you to focus your energy and time on making the important decisions. One example, in a GP practice, for example, you could have an AI tool that triages your patient as a doctor, and it gives you and your assistant already possible diagnosis just based on the interaction with the person. But you still have to apply your medical knowledge to actually make out of the differential diagnosis, which diagnosis works better, according to your interaction with the patient as well. So for me, I think the first thing is to understand that AI cannot replace, not today, it cannot replace the actual brains of a medically trained specialist in the area of field. So it can't, for now. I know there are optimists who are saying in the future it just might. But I think for a country like ours, if we bring it home to our context in South Africa, one is that people in the rural areas, and sometimes even in the peri-urban areas, they don't have access to specialists. We literally, as a country, sitting at, I call it less than half a doctor per 1,000. The WHO recommends at least one doctor per 1,000, at least one. And that's like with the bare minimum. South Africa sits at 0.31.
Jeez.
Per 1,000. So that tells you, Mandisa, that for every 3,100 people in South Africa, there's only one doctor.
Very concerning.
Now, I mean, and also it doesn't really tell you what level of skill that doctor is. So to your point that, I mean, you've got 1,800 doctors outside of the system. Even if you were to bring them in, it's a drop in an ocean to get to at least that one doctor per 1,000. So, but then with technology, you can say, okay, how do we support the rural clinics? How do we make sure that people who get there are actually seen by nurses, but with the support of doctors? Because whether people like this thing or not, and it's the truth, doctors lead the clinical teams. It's accepted. Doctors are the highest trained at that level to lead the clinical team. So you almost need I was making an example earlier on when we were having a conversation that you could train nurses in a central hospital. Central hospital is where you train doctors. And then you can train nurses and all these healthcare professionals for a smaller hospital, and you invest on one of the key pillars of a health system, which is equipment and infrastructure. So you could build an ICU in a remote hospital for access. Train the staff by the team that is at the central hospital and monitor the monitors together with them while sitting at the central hospital. So you have not taken jobs away. So people are still there because they have to react. They have to react when the condition changes. But the level of reaction is informed by specialists in the field. So it's not just a reaction of a junior doctor. It's a reaction of a trained junior doctor by a specialist who's also being monitored. And maybe that's another thing that people miss in medicine, that the hierarchy of the level of specialization gives you some sense of comfort as a junior doctor if you've got someone who's a specialist who's watching over you, you can reference to. So it becomes very, very important. So we think that that's the one thing in which we can bridge the access gap. But for SAMA, the most important thing for South Africans is that universal electronic health record. So when we held our first AI roundtable for the health of the nation last year, we invited Minister Bladensmand from Science and Innovation. And he committed that he's going to talk to the Ministry of Health. We have a planned meeting with both of them in May the 20th. The agenda item is that South Africans need one source of data, of patient data. South Africans, whichever corner of the country you are in, doctors, when they see you, and the nurses, when they see you at the clinic, they must be able to get your information and know which medication you are on, whether you have the clinic card or not.
Yeah.
We can get it from the system.
Yeah.
If as a country we can achieve that, we would have moved, what is called quantum computing. From the system that we are in, would have jumped, almost overhauled the system and guaranteed the universality that the NHI is attempting and failing to do. But we would have come very close to the concept of universal health coverage. We can predict diseases based just on that date. We can tell what South Africans will be suffering from in the next 5 to 10 years.
Yeah.
We can do precision medicine. We can literally tell each family. People who are training in medicine today could actually do their MMeds on tracing what are the things that South Africans are prone to.
Yeah.
So the spin-offs from that, from a system point of view, and from a research and development point for the country, that's unmeasurable. And it's not something that it's not done. It's everywhere. The models for that exist in other countries that are not even economically different from us, from an economic point of view. So we hope that these conversations that we have with the various leaders within government would allow for almost a sober kind of an approach to things. The Department of Health is today experiencing a problem of medical legals. And one of the major things is that records are stolen from hospitals. But if you have that in a server, your only risk is cybersecurity, which is a risk that everybody in the world is dealing with. Yeah. So, but you don't have your records stolen. That's rudimental. That's So for us, I think AI is access for those people who don't have access to specialties. The second thing is the spin-offs that could come from us harnessing data for research for the benefit of all South Africans.
Yeah. So I'm hearing enablement, lots of enablement. I'm also hearing increased, ability to respond quickly, more effectively to patient issues, really.
If you can prevent diseases, that's what we call nirvana.
Yeah.
That's what you want.
Yeah.
People not waiting for them to get sick. You intervene early, and you can. I was talking to you, I think earlier on, that I spent about a month in Taiwan, and they were taking us through the training of how they've applied AI as a nation in healthcare. These guys, they can detect pancreatic cancer when you can still operate. In South Africa today, we aren't able to do that.
Yeah.
So, and we can't, the difficulty about AI is that ethically, you can't translocate what the Taiwanese have done with their own data into South Africa. You would have to train models using the South African data.
Yeah.
So that in South Africa, okay, so if it's like this, then that tells me that I can still operate. And you can prove it. So if the machine tells you that this is pancreatic cancer, you go open the patient and you find that it's early stages, the evidence is there.
Yeah.
So for me, I think the country is almost, I don't want to say ignoring one of the things that we could, transform. We can overhaul the health system and access to healthcare by just embracing technology, but with very strong clinical and ethical leadership. Because we need to know who then takes responsibility if things go wrong.
Yeah, and in this instance, it's not just leadership in your profession, it's leadership from a government perspective as well. What you're saying is something I'd be willing to put my money behind.
It's the return on investment that when you put on that. For me, it's almost like a deja vu. I was trained in a system that focuses on primary health care. And I can tell you, when I started reading the initial papers on NHI, I was sold because it was focusing on primary health care.
Yeah.
Now, bringing technology into primary health care, there's savings you can make. I mean, Cuba prides itself by solving most of health problems, 80% of health problems at primary health care level, like the example I was making about pregnant women. So then, and the difference between the developed countries and developing countries and the underdeveloped one is the investment they make with every rand you spend on healthcare is not actually an expenditure, it's an investment.
Yeah.
So healthy populations actually become more productive.
Yeah.
So for me, I just think there's a shift that is needed in leadership.
Yeah. So much of what you're saying, highlights the interconnectedness of the solutions actually in that space. One of the things you were referring to earlier is the focus, the disproportionate focus of the NHI Act now, on finances over all other pillars. But the example that you are giving now illustrates just how looking at something that's not directly finance related really enables you to achieve the financial outcomes you want.
And the savings you want to make.
Yeah, precisely. And for me, that actually also it's just an odd thing to hear you say that the NHI is super focused on finances, because one of the things I deem to be gripes in your profession is that increased money motive, right? And how it detracts from what your profession is about, cultivating health and creating wellness and enabling people to live nice, healthy, happy lives.
If government could look at the potential benefits of investing in AI in healthcare and investing in primary healthcare, the savings we would make as a country. I mean, the expenditure, the way we're funding health, the money we're spending on healthcare today, which in certain provinces we're even unable to spend because of lack of leadership, it goes back to Treasury. If that money can be redirected to, maybe as a first step, just making sure that both public and private sector, when it comes to that record, that health record, we invest on that.
Yeah.
Whether you are accessing the system, whichever of the two, but as a bare minimum, we are able to get your information.
Yeah.
So then the other things just come because then we have reliable data, then we can train models, then we can do all of these things. So for me, I'm hoping for a shift in leadership, and I say this because when I was in the Chinese Medical Association invited us, and they invited us to one of the remote provinces of China. And they also showed us how they're using technology. When I was there, I immediately called my province. I was like, guys who I left in the system, guys, I'm in China. I'm in almost a replica of the Eastern Cape. Mm-hmm. But these guys, with the kind of service that they are rendering to their people, literally in every specialist room in the hospital we visited, they have a big screen that allows them to talk directly to all the hospitals that refer to them.
Yeah.
How much is that when you have internet in a box now? So you can argue that there's no connectivity in rural areas.
Yeah.
You can literally put in the internet as an investment as government.
And also when you have departments that are returning money to Treasury at the end of the financial year.
So you can take that money and invest it.
Yeah.
Even centrally, if you decide, this is one of the things that we were talking to the minister about, the unemployed doctors. So one of the things he was saying was that the then minister gave money to provinces to appoint doctors, but that money was used to buy, other things. So, but what you are saying is that government, centrally, they can decide that, look, we're going to invest in technology.
Yeah.
Centrally. They can create a conditional grant that is basically for investing and making sure that there's connectivity between hospitals, as an example. Why don't we bring in our partners as a country, leverage the relationships that already exist, and just pick the low hanging fruits for healthcare. I mean, for me, I always say this, that if the healthcare system in South Africa can have almost like a digital or technological infrastructure that is similar to what the financial infrastructure has in South Africa, we will be untouchable in the continent.
So what stops us going there?
Leadership. For me, it's leadership.
It's back to leadership.
Yeah, for me, it's leadership. And us being able to listen to different voices. For me, it's also learning from our partners. I mean, you can't go to Taiwan and China and come back and not have a problem. If you come back, if you visit those countries, you see how much they've invested on technology and how much it benefits. I mean, you just can't. I don't understand, how do we go to these countries, have them present what they present to us, which is not significantly, they are not economically different from us. Some of these countries are smaller than our own economy. China is big, I agree, but they are our partners in the global. Why can't we leverage that to our own advantage for the benefit of our people? So for me, I think it's leadership that needs to shift from just a perspective of embracing technology and accepting the risk that comes with it. We are ready to provide clinical and ethical leadership in that space so that people take responsibility for the machines that they're bringing in. But also, we think between medical schools and computer science schools, there has to be some sort of a relationship. Because when you actually go and understand what AI is, it's actually not different from how the central nervous system works. So they use a neural network which transmits information. Deep learning is basically neurotransmitters talking to each other. So I mean, medical training could have AI component in it, so that by the time a doctor comes out of med school, they've got an idea, so they've got a buy-in of the system that they will be working in.
Yeah, I'm looking at your excitement when you talk about type and China. And I'm starting to get concerned that maybe your travels there should be restricted, because just now you decide to move there.
For me, it's the learning.
There, right?
It's the learning experience. It's the learning experience. You can't have leadership. For me, I would have more South Africans traveling the globe and getting the nuggets and bringing them back into the system. For me, that's key. Especially things we can achieve. I mean, low-hanging fruits, things like screens. I mean, how many government offices you go to and you've got big monitors? Put that in a hospital, put internet in a box.
Right.
Let professionals talk to each other about a patient.
Yeah, so whoever is listening in government, please sort out our AI issues. We don't want to lose doctors because they want to go play with better toys elsewhere. We need you. And then let's segue then into this thing with shortage of doctors and unemployed doctors. What is that about?
Yeah, so there's two things there. Again, I think for summer, I think the main thing is planning. Mandy, we know today.
Yeah.
Today, we know how many students in med school today are doing final year. So we're very clear. We actually knew when they started at first year.
Yeah.
So some 5-6 years ago, we knew how many what would be the output. We knew. So when I was
Just
sent
share
to
those
Cuba,
numbers with.
so South Africa, without the Cuban component of it, I think by 2012 we were producing just over 200 doctors every year.
Yeah.
Now, with the Cuban there was a debate at that time, I think it started in 2012, that can they increase the numbers of medical doctors because of the shortage, of course. And then the Cuban program was almost at its infancy. It had not produced doctors. But when the doctors, they actually increased, when I got the scholarship, we were 10. Just 10 from my province. But, when we came back, we heard that now they've increased the numbers to almost 100 per province, which is a good thing. But when you do something like that, you need to almost align it with planning of the platform that these people are going to come and work. So we're not really certain that that process took place properly.
Yeah.
Because then we wouldn't be sitting where we're sitting. But when we engage with the ministry, we discovered that, in fact, there are posts that are available across the country. And they are over, I think the human resource said something over 2,300 across the various provinces. And these are medical officer posts. But there was no funding for them. So the problem then became finance more than availability of posts, which then almost counters the argument that they did not plan. They planned, but you can't plan for posts and not the finance, because you need to actually have the money to do that. So that's the one thing. Then government then wants to move into reducing. They make the argument that if we reduce the number of hours, remember I spoke about overtime, that doctors actually work, we can save some money there and appoint the unemployed doctors. Now, let me tell you why that argument is dead in the water. The skill sets of the doctors who are outside of the system and the ones who are inside the system completely different.
Not the same.
So if you reduce the overtime of an obstetrician in Steve Biko Academic Hospital, who's going to operate on those patients at night?
Yeah.
And you are bringing in a junior. So it's just, that argument just doesn't. And in a country that is got less than half a doctor per 1,000, So all we need is a serious discussion with Treasury on how we fund the healthcare system, and maybe a human resource for health strategy. And South Africa has done well in terms of research and projecting even the quality or the type of specialists we will need by 2030.
Yeah.
So we've got that work done. But that research needs to be incorporated into planning by government, but also taking into account that there's technology now. So how do you incorporate that in your human resource strategy? And I think Treasury needs to understand what I was saying to you earlier on, that a rand spent on healthcare is an investment.
Yeah.
So thriving or healthy communities, they actually grow their GDPs by leaps and bounds. So that's a discussion that we probably need to have as key players within the health sector, but with the business as well. Because, businesses that are operating in South Africa, they need healthy South Africans to actually work for them. So we probably need to see how do we find a way of funding those posts that are available.
Yeah.
So one of the things we've done as SAMA is that we've run a survey of the guys who are unemployed, who are outside of the system.
Yeah.
And what's interesting, Mandisa, is that what is coming out of the survey is that these guys, it looks like they've read the research that is out there. They actually want to specialize on the fields that the country is set to be in short of by 2030.
Nice.
Yeah, and we then, we've engaged players within the health sector like Discovery to say, can we start a fundraising process to fund these posts that are available, especially the training ones, within the public sector, so that we can allow these guys to be trained while rendering a service? Because that's a different thing when a doctor is training to be a specialist. They're being trained, but they're also qualified doctors already, so they're rendering a service. So from our own, I think from the Finance and Risk Committee, we've got a fund that is called the Benevolent Fund this summer. We've put aside seed funding of about 5 million as a start, but I mean, that's just a drop in the ocean to fund a specialist. We engaged Discovery. They've got a program that they fund post-doctoral qualifications. And then we said to them, look, in your foundation, can you consider redirecting those funds to junior doctors who want to be specialists? Because postdoctorate are guys who can afford actually to fund themselves. So we've got that discussion with them. They seem to be interested to redirect funding. We also are trying to talk to our global partners to see if they can contribute so that it does not look like, we really don't want to look like complaining. People who are not coming with solutions. So we're willing to put in our own money from the company and raise funds with our global partners to make sure that at least there's training for what the country needs.
Yeah.
The other thing is training doctors on leadership so that they can take the leadership roles outside of just what is clinical to plan for the country. We've got a partnership with a university in the US called the UAB in Alabama, where we're offering mini MBAs to the doctors.
Yeah.
We've spoken to CETA so that we can make that free for the guys who are unemployed. So there's quite a lot of work that we're doing in that space, because we really cannot just sit and accept that government doesn't have money.
Yeah, and I commend you and the rest of your peers in that space, right? But I just want to take this opportunity to say that we've South Africa right now, where we are, we've allowed a lot of inaccountability from our authorities, and we shy away from what we label as complaining, when really we are raising legitimate issues as taxpayers who are entitled to expect some of these things and are entitled to have explanations when those things are not happening. You know, so as much as I appreciate people standing up and doing something about it and would absolutely advocate for that with anybody, I also, one of the things I advocate for is for people to speak up more. And when you speak up and raise legitimate issues, can we please not label that complaining? It's not complaining, it is talking about the reality of our situation, and we're entitled to it, and we must hold our authorities accountable.
No, my sister, I agree with you 100%. I mean, when we are invited in platforms as Summer to speak, we at some point we were almost the only voice, within the health industry that was openly challenging government on the NHI. I can tell you it was very cold.
Yeah.
But we were convinced, as we are convinced today, that we were on the money.
Yeah.
Representing the patients who are interlinked, because doctors' rights are interlinked to those of their patients. So we were very comfortable. I mean, I remember this other time I was with Nicholas, the director of the NHI at National, and I told him that we're very comfortable to be the lone voice, very, very comfortable, because we believe in what we are saying. And we are not fighting government. We are not a political party. We're not interested in politics, but we understand healthcare. We've got expertise in healthcare. We understand how the world is moving in relation to health systems. So it's not a war of, we're not struggling for power with you. We just want the best
Yeah.
for our people. So I agree with you 100%. But at the same time, we have a responsibility to our members to give them alternatives. You know, to say, look, you could do this. They even said, our members also, they wrote to us and said, Sama, is it possible that you guys can look for these unfunded posts, and if you can raise funds with the responsible corporate citizens, the companies that are operating in South Africa, you can then have this funded through that vehicle. We said, we can do that. We've already have stakeholders that are interested in the industry. Even banks, the way they look at a doctor is, I challenged them. I said, look, you are there first thing when these guys qualify, giving them all of these loans, But now the environment has changed. The country needs them, either as specialists or as GPs or as people who want to be entrepreneurs. So the discussion between the bank and the doctor client must change.
Yeah.
If my bank can fund my specialization, I would never leave them.
Yeah.
So I would be loyal to that bank forever. Because that's significant contribution in my life, and when I become a specialist, I will bank my business with that bank. So these are the conversations we're having with South Africans from the different walks of life that start looking at this thing differently.
Yeah.
Absolutely.
And that's another thing that makes zero sense to me, that we are creating artificial funding related issues. We don't have a funding problem in this area. Where's the gap? Where's the money dropping to? One of small example you mentioned is money being returned to Treasury. We see the Auditor General's report about monies that are spent either in an irresponsible manner or unaccounted for. So it can't be that when we have meaningful issues to address.
Money is not really our problem.
Yeah.
How we manage that money, and the issue touched on corruption. Corruption is the worst thing. It robs South Africans a lot more than what we can imagine.
Yeah.
For me, that just pains me, because without corruption, just taking out corruption and how we lose money in the system, we could do far more bigger things than, that's just a painful thing for me.
Okay, so thank you so much for sharing your vision with us. And I'm really excited to hear about the things that you deem to be necessary to transform the health system. I'm going to give you a magic wand. 3 key things that you would do at a practical level now to change things for the better tomorrow, whether it's be at the systemic level, at a community level, in healthcare.
Have government accepting the crisis we have in leadership and governance in healthcare, so that we don't have money going back unspent.
What would that look like in practice? How would you know they've accepted it?
So for me, it's an engagement. I think for me, if something could happen, the magic thing, one could whisper in the ministry's ears to say, engage the profession. How do we do this? How do we train? Even that we don't have to remove the guys who are there.
Yeah.
But let's train them on the key skills that they need to actually lead hospitals.
Okay.
And we can give them the delegation in terms of the authority that they can. And the second thing, please implement yesterday, find money, implement yesterday, but with proper planning, the universal electronic record for all South Africans.
Wonderful.
If you do that for South Africans, the rest is just spin-offs from that. And I think for me, the last thing is for South Africans now, both in the business and in the different sectors, to understand that, and this is almost more like a message for Treasury and businesses in South Africa. what we've been saying, that every rand spent on healthcare is not an expenditure, is an investment for the country. Thriving people as a nation will grow this GDP, the GDP of this country, to levels that we cannot even imagine.
We've got the tagline for this episode, right? So we'll be part of your communication drive to spread the word. Dr. Theo, thank you so much. I've really enjoyed chatting to you today. Is there anything from your end that you feel you'd like to leave us with that we haven't covered?
No, except thanking you guys. I mean, FireSide, I think these are platforms that we actually need to communicate our vision for our country. So I want to thank you guys, and I want to give a big shout out to all of you guys here. Thank you very much for the work you're doing.
Thank you. And thank you for the work that you do, and I wish you great success. I hope you win in all the important endeavors that you're driving.
And I'm not going to Taiwan.
Yeah.